Good evening, everyone. It gives me great pleasure to welcome you all to this 11th episode of Endocrine Talk Show. We all know that understanding of how to investigate and diagnose endocrine disorder is of utmost value. And in today's session, our esteemed panelists will discuss various endocrine investigation and their appropriate utilization in clinical practice. So to moderate and chair today's session, we are having with us our co-director for the program, Dr. Chaudhary sir, who is an integral part of this webinar series. Dr. Chaudhary has been an invaluable asset to our program and has constantly provided valuable insight and expertise. So we look forward to another informative and engaging discussion. So with great pleasure, I welcome Dr. Chaudhary sir to this digital podium and request him to introduce our panelists for today's program. Over to you, sir.
Thank you very much and a warm welcome to another episode of Endocrine Talk Show. We have had a wonderful run over the last so many months. Initially, it was designated as Practice Pearls in Endocrinology. Then we evolved into Endocrine Talk Show. And we've been blessed with experts from all over the country. And of course, by your valuable presence, our participants, our audience, who have shown interest over every month. And we have got figures that are provided by the INTAS team as to at least about 1,000 individuals joining on each occasion. So welcome to you all. And this evening is no exception. We are blessed by the presence of the teacher of teachers, Professor R.V. Jayakumar, who was instantly also my examiner in the DM exam, and is one of the senior most endocrinologists of the country. He's currently at the Aster Med City, Kochi, and Caritas Hospital in Kochi, and has had so many important roles, positions, including past president of the Endocrine Society of India and past president of the National RSSDI, as well as the founder president of Indian Thyroid Society. So welcome, Professor R.V. Kumar. We also have with us, if not right now, will soon be joined by Professor Ashraf Ganai, who is professor in the Department of Endocrinology from the Sher-e Kashmir Institute of Medical Sciences in Srinagar, Kashmir. He is also sub-dean research and head of the Department of Clinical Research at the same institute, and he has also a vast experience, and he is also leading the ICMR PCOS study, a land-breaking study, the largest study of its kind in the area of polycystic ovarian syndrome. We were supposed also to have Dr. Shailesh Lodha. Unfortunately, because of some other family commitments, he could not join from Jaipur. But we are indeed happy to have Dr. Sandeep Julka, who is senior consultant endocrinologist at the Department of Endocrinology at CHL Hospital, CHL Care Hospital in Indore. He also, of course, is a very well-known, renowned, and experienced endocrinologist. So as and on other evenings of this program, we would all of our participants put in their questions, and I'm sure, as always, Dr. Mithilesh Naik will put the questions in our chat box, and we'll try and answer as many of them as possible. So till we get the questions from our audience, maybe we'll kick off on our own and try and find some areas to discuss with. One of the very common areas that we all face is diabetes. And we often get people who have maybe borderline blood glucose value. So let's talk of a patient, and we welcome Dr. Ashraf Ghani. Welcome, sir. And so let's talk of patient, real life patient, a 55-year-old gentleman who comes with a fasting glucose level of 125, and is part of an annual health checkup. Doesn't have any specific complaints. So can I ask on maybe the experience of Professor R.V. Jayakumar, So what would you do with this individual?
Thank you, Dr. Shubhankar, for the question. And first of all, let me thank the organizers for inviting me for today's session. Okay, now this is a common thing you get across nowadays. Wellness clinics and executive checkups are very common in nowadays. People without any complaints go and have it a checkup done. And the question is, now it is 125. If you want a diagnosis, if the guy, and he said he has got no symptoms at all. If you want a diagnosis, a classical, it is a pre-diabetes because he does not belong to the normal category, nor does he entertain with the uh, type 2 diabetes. So now the diagnosis is pre-diabetes, but if you want to confirm this, you cannot tell anybody on the basis of a single reading that you have got a disease which has got a long-term prognosis. So I will best tell him that it seems that you are not normal, but I would like to confirm your glucose status by doing a fasting and a 2-hour postponed after say 100 million dose and a hemoglobin A1C. So with these 3 tests, I will be able to tell him whether he belongs to the pre-diabetes category, whether he becomes normal or he is in the diabetes category. Because as you know, the 2 readings must be abnormal to make somebody as diagnosed of diabetes more than either fasting or postprandial or a hemoglobin A1C more than 6.5.
Let's say, like the fasting, the other test that you asked for, post glucose load test, HbA1c, also fall in the category of pre-diabetes. Now, what do we investigate this individual further? For example, we know that even people with pre-diabetes are at a higher risk of myocardial infarction or macrovascular disease overall. So, do we need to investigate any further in terms of biochemical tests?
The thing is that with a 125 reading alone, one single reading, it is not justified to stamp somebody having an abnormal glucose intolerance. So
No,
either at least
what I was saying is the other test that you advised, a post glucose load test and an HbA1c, also suggest that this gentleman has got pre-diabetes. So should we ask for any other tests or just
no,
advise some lifestyle modification?
that is about the management part. Management, you said he is not having any symptoms. I would like to get his height and weight, whether he has got signs of insulin resistance like acanthosis nigricans, and find out his lifestyle pattern. And always better, no harm in giving advice about lifestyle changes of keeping his dietary habits and having a regular exercise. And the most important thing is monitoring whether he is going to be remain in this state, or whether he is going to become normal, or whether he is going to become diabetes. That is the most important thing, that he must follow up his diabetic status by a periodic assessment and see whether he is going to proceed to diabetes or whether he is going to be relieved of diabetes.
Absolutely. So we need to follow this individual up as well. And as we know that even in the stage of pre-diabetes, the risks of macrovascular disease are increased. But I suppose as part of this health checkup, he would also have had a lipid profile. So if he has not had, maybe we'll also check his lipid profile, likely also request for an ECG. And then, of course, we have to follow up. That's very important.
As Dr. Subhaga, I forgot because I was told that this is the only abnormality after executive checkup. So I took it for granted that his lipid profile, his renal status, his ECG are all, because ECG is a basic thing which you do in our executive checkup. And so because I was informed that he is the only abnormality which he has come across, that is why I didn't do that. That is that above, he is 55, and any person above 40 plus going for annual checkup must have a lipid profile and must have a ECG done, because the age group 40 plus is going to be bigger things.
Right. And I don't know about Kochi or Kottayam, but in Bengal, in Kolkata, most people will get a uric acid test done for whatever reason because of aches and pains. So do you think uric acid is something that is very important to be checked?
I think all the executive checkup includes uric acid also, and a person with now it is well known that the uric acid is a component of metabolic syndrome, And metabolic syndrome is the commonest cause of type 2 diabetes, obesity, hyperlipidemia, which you come across in our country. So it is a fact, but too much of treating. I personally feel that reading of slightly elevated uric acid, people, many of the physicians, them to start treating this with the drugs, pharmacological treatment. I think that is too much. That is a part and parcel of the metabolic syndrome, and the fact that once you control his diabetes status and lipid status and his weight and his irregular exercise, ask him to repeat. If it is abnormal, ask him to repeat the uric acid later on and find out whether it is contributing to it. Otherwise, I personally feel that it is an over treatment of uric acid by many other physicians.
I would agree. And can I ask a quick one to Sandeep, because we are on the area of diabetes now. Only though we have been told that GLP-1 analogs, and now use of GLP-1 analogs has also increased even in our country, despite the cost, that they do not significantly increase the risk of medullary carcinoma in humans. In rat experiments, yes, they do. So, with so many people with GLP-1 analogs, would you or do you advise calcitonin measurement once in a while as part of routine management? Or should we do it? And I raise this issue because of this recent look at the French database. Previous ones suggested there is no increased risk, but this French database suggested that there is increased risk of thyroid malignancy overall. So, Sandeep, a quick one.
I think I personally don't agree with that calcitonin, but I would like to hear the opinion of other experts sitting here based on this study from France. I have not asked a person so far on GLP-1 to go for a calcitonin assessment because of the so-called possible connection with this, and I have not come across with the latest. I'm aware of the French study, whichever it is. So I would like to know your opinion and other panels' opinion on this.
Yes. So in case of any medical difficulties I face, I can immediately quote that my teacher, my examiner, Professor Jayakumar, doesn't test, so I also don't test. Fine. So Sandeep, please, your view.
So thank you so much, Dr. Shubhankar, and great listening to Dr. Jayakumar. Thank you for having me here. So incidentally, I've been involved with clinical trials with semaglutide and then now with tirzepatide. In all the clinical trials, we have a baseline calcitonin done. Till now, over almost 10 years, we've been prescribing GLP-1s. I have never got a calcitonin done for my patients. And I don't think there's a recommendation to do it. And I have never ever faced any problem. Not that we screen.
Right. So we are on the same page. Ashraf?
Yes. Yes.
Please unmute yourself. Unmute yourself.
Hi. Thank you, Professor Shubhankar. I think very well discussed, very important point. I also know I have not seen so far any patient having this. However, I am just aware of some data being done in preclinical studies that they say that if you calcitonin agonist combined with some drugs like metformin has an agonistic effect for preventing prediabetes, what Dr. Jayakumar was saying. So these are in rat experiments. So that way, probably there is calcitonin agonist is going to help. So calcitonin may have a relation there also for diabetes. However, these we have not been able to see any case with GLP-1 analog.
Right. Absolutely. And so we are all on the same page. So now we have a question in our chat box, Dr. Darshan Shah. So this is about, it's important, endocrine hypertension. So which investigation to recommend first in patients with resistant hypertension with normal renal function conducted 3 months back, and what cutoff value do you follow for aldosterone-renin ratio to diagnose primary aldosteronism? We do understand that in recent times, and thanks Dr. Darshan Shah for raising this issue, that probably primary aldosteronism is not as uncommon as we, even as students, believe so. Studies do suggest that even in the category of essential hypertension, there may be some patients with primary aldosteronism where we have a treatable cause. So, can I ask Ashraf to answer maybe where do we suspect primary aldosteronism? And then he has asked specifically the cutoff value for A to R ratio, aldosterone ratio.
Yeah, sir, as you rightly said that aldosterone, hyperaldosteronism is not as uncommon a disease. When we say the dictum in endocrinology is generally when you see that the more than 3 drugs are required for hypertension, you think of a secondary cause. And when you are out of secondary causes, if you had inadvertently given a diuretic and you feel that there has been episodes of hypokalemia, or there is a even spontaneous hypokalemia, in that situation you try to do a screening test, that is aldosterone level. And it is said if you have an aldosterone level of more than 15 at basal level, in that situation you may probably have a very high odds of having hyperaldosteronism, and you may not go for renin aldosterone activity as is done routinely. There is one important issue in our country which we should say that doing renin and doing aldosterone by the common garden variety labs may be problematic. So we also have interference with drugs. You know, a lot of pharmaceutical agents, all antihypertensives which are given need to be stopped at least for 2 to 3 weeks, even 4 weeks, or some of them for 6 weeks. So then only you may do a provocative test or a stimulatory test, or you may do renin aldosterone ratio.
Right.
So,
Yeah.
so that is sort of a endocrinologist says we have actually, if you in general, if you feel aldosterone is above 15, in that case you have very high odds of having. Recently we did a case study. We did even the adrenal vein sampling also. We did everything. Ratio did not favor. Still, I told the surgeon that I have a very strong suspicion this young lady may have hyperaldosteronism. We did one unilateral adectomy and she went into a sort of remission.
Right. Yeah. Our suspicion, of course, in resistance hypertension rises, and especially if there is hypokalemia, especially if there is spontaneous hypokalemia. But having said that, we also do remember that even normokalemic individuals with hypertension can have primary aldosteronism. And if you are specifically, and of course, Dr. Ashraf has very correctly pointed out the issues of measuring aldosterone renin. They are not easily available. They are costly. We cannot go on repeating those tests, at least in our socioeconomic status most of the time. But if you're asking for a specific ratio, the higher the ratio, the more likely is the chance that there is primary aldosteronism. Typical figures that are taken above 15, even above 20 would be better, and that should ideally be accompanied by significant elevation of aldosterone value, as well as Dr. Ashraf has already pointed out. Now, we will come back to questions from the audience, but can we, because diabetes remains one of the commonest endocrine conditions that you and I all face. So while on the issue of diabetes, can I ask Sandeep, so how often or do you ever screen for NAFLD? And now some people are saying it should not be called NAFLD, it should be called MAFLD, metabolism associated or metabolic syndrome associated fatty liver disease. So do you routinely look for it? If you look for it, how do you look for it?
Thank you so much, sir. Now, so I was reviewing MAFLD when a pharmaceutical company engaged me to speak on MAFLD on NAFLD. I said, what is in a name? But then it is this single NAFLD which we now know is the cause of cryptogenic cirrhosis, the leading cause of cryptogenic cirrhosis. it is the #1 cause of liver transplantation in the US, and it is also probably high on the rung of malignancy, hepatocellular carcinoma in the US. So it is just very imperative that we screen for an NAFLD or MAFLD. Majority of patients with NAFLD have MAFLD, as Dr. Jayakumar just stated, that uric acid and the central obesity and the triglyceride and the blood sugars. What is more important, they did a study of those with just isolated NAFLD versus those who had other metabolic factors as well. They progressed faster to cirrhosis and to hepatocellular carcinoma. So there is probably some truth in saying that you can rename it as MAFLD, although the treatment will not matter. It is just you have to be very, very careful.
Test, what test will you advise to pick up?
Yeah. So screening is very important. Keep a watch on your SGOT-PTs. SGPT is usually more than SGOT. Sometimes you may not have a rise in SGOT-PT, but still have fatty liver and some hepatitis as well. And also keep a watch on your platelets, because once those platelets starts falling, then you know that there is something wrong with the liver.
Right. Great. And do you also go for sound of the liver, scan of the liver these days?
Yes, we do, sir. Yeah. Now, one is ultrasound. The ultrasound does not pick up fat unless it is more than, say, 30%. Usually more than 5% fat is considered as fatty liver. Fibroscan is very important, is a fantastic investigation, OPD procedure. By that, you know the elasticity of the fat cells and hepatocytes, and it is given in Pascals. Beyond 8 states that there is NAFLD, and then beyond 15 or maybe more, it shows that there is some amount of fibrosis. So, and most of our gastroenterology colleagues have in their clinic at least a week, once in a week, the machine comes. I think we physicians should be more proactive in getting the at least an ultrasound and then a fibroscan in these patients.
Right. So, apart from diabetes, I think the other most common endocrine problem that we have to deal with is thyroid disorder. And amongst the thyroid disorders, hypothyroidism is definitely more common that we see than hyperthyroidism. And we have Professor R.V. Jayakumar, who is the founder, president of the Indian Thyroid Society. So actually the first question related to thyroid should be addressed to him in all appropriateness. So we have a 35-year-old lady with hypothyroidism who is already diagnosed, is on thyroxine treatment, and who visits your very busy clinic and gets a chance to see you in the evening, only 6 in the evening. So what tests should we do? And is it okay to collect the blood then and there? Because labs are often very helpful, try to be helpful. So they draw the blood then and there. So is it okay to get a blood sample taken then?
Okay, thank you for the question. See, the thing is that hypothyroidism confirmed patient, and she is on treatment according to you. And the fact that she is coming to you is to find out whether we must alter the dose, titrate the dose, whether to step it up or down depending upon this. So usually internationally, everybody says to only depend on TSH value. TSH value, on the basis of that, you will make up your mind whether to increase or decrease the dose. I personally feel that TSH alone is not enough. You must do a T4 and TSH together. There's no role for T3 because T4 and TSH together, because the labs we are going to depend on a single value, and there can be some error. There are the chance of having two errors for both for T4 and TSH is going to be much less. Second thing is, it must be, all of us knows that there is a diurnal variation of TSH. And if the patient, as you very clearly said, the patient is coming at night, what should you do and all those things. So you'll have to look at the practical aspect also. See, if you are going to ask her to come in the morning and have the morning test, the chance of her turning up is much less. Whereas if you are going to take a sample at that time, at least you must know, you must be able to convince yourself that she is in the normal, she is receiving the necessary pharmacological dose of thyroxine. So I will, even though it's not 100% perfect, and I think the marginal value alteration which may occur in the evening hours is not going to affect her thyroxine dosage prescription by you. I will personally take a sample at that time. And next time, ask her that next time, if possible, come in the morning and do it so that we will be able to give you a better idea. But because he is already here, coming from a far place, do it and adjust it. And I personally make the patients do T4 also in addition, T4 TSS together, so that I am very 100% confident that the low TSS value which you get maybe due to other drugs, like especially metformin therapy, the many of the patients are diabetic, it can alter the TSS value. So basing purely on the basis of a single TSH value to alter the dose, I am not against, but there is no scientific proof for it. But this is my personal liking. I do it.
So it's absolutely the practical, pragmatic Professor Jayakumar who is speaking, and of course from a lot of experience behind it. But sir, is it T4 or free T4?
No, see, the thing is,
we advise.
I advise only T4
Okay.
because free T4 all over the world is accepted to be giving false results. So can be given false result. I'm not saying everything. So and T4 is cheaper than free T4. So I will be happy with a non-pregnant lady having a total T4 and TSR rather than a free T4.
Fine, thank you. So we do have a few more questions in the chat box. Dr. Mishra asks, do you see any value of 1 hour postprandial glucose or 2 hour postprandial is more valuable? Dr. Ashraf, would you take
The question is that do you
1 hour or 2 hour?
Would you suggest 1 hour or 2 hours? Very good.
Yeah.
So I think the conventionally with OGTTs, we have been actually taking 2 hours. However, we see some conditions where insulin resistance is more. You may have 1 hour impairment. Typical example is our PCOS. When we calculate what is called whole body insulin sensitivity, we take even 30-minute sample, because the impairment is more severe in the first half of the OGTT. But when you have to compare this data or the global descriptions and all, then we take 2 hours. That is why in insulin resistance status, for example, in gestational diabetes mellitus, when you have to treat and watch the glycemic excursions in them, the recommended is 1 hour measurement rather than 2 hours.
Right. So for diagnostic purpose, still it's at the 2 hour.
Diagnostic purpose is 2 hours. Yes. Although conventionally 1 hour value was also taken, but now we say 2 hours.
But in the context of gestational diabetes, maybe 1 hour value could also be quite valuable.
Useful.
Yes, not only gestational, diabetes with pregnancy, whether even established diabetes.
Yes. Yeah, right. So we right. So can we go back to Sandeep and ask about, so we just talked about hypothyroidism. What about hyperthyroidism, who is already on treatment? Carbimazole treatment started maybe 6 weeks back, and you ask the patient to come for follow-up. So what test should we do? T4 and TSH, as Professor Jayakumar suggests for hypothyroidism, is it something different? Please unmute yourself, Sandeep.
Yeah, sorry. Can I have your question again, sir?
The question is, Professor Jayakumar suggested T4 and TSH for following up someone with hypothyroidism. So someone who's been recently started on treatment of hypothyroidism, maybe 6 weeks back, now has come back to you. So how do we assess hormonally? So is it still T4 TSH?
In hypothyroidism, sir, or hyperthyroidism?
Hyper. Now hyper.
Sir is talking about hyperthyroidism. Recently started on treatment 6 weeks back. How do you follow? What is the
Yeah,
way of following.
yeah. Thank you so much. So now I get it. So in hyperthyroidism, we definitely need to do a TSH and a T4. Sometimes you have what is known as a T3 toxicosis, where you might have to measure T3 as well. We know that T3, T4 comes down faster and TSH remains suppressed for several months when you're treating hyperthyroidism. But then definitely you may do all the three, TSH, T3, and T4. Um, and of course, for free T4, we usually don't test free T4 unless probably in pregnancy. That is the only place probably we would like to do a free T4. Otherwise, usually it is only total T4, total T3, and a TSH.
I don't know whether
We
the
here, sir, can I just add to what Dr. Sandeep very nicely
yes,
said? Generally, what we have seen, if we go on doing TSH in these thyrotoxic patients, it doesn't recover even in months to years. So whether this TSH doing will help much or not, unless when you have erroneously made a diagnosis of thyroiditis, TSH then in them recovers quickly, but as Graves' disease or autonomic functioning nodular toxic multinodular goiter, TSH doesn't recover for long.
yeah. So generally, I possibly wouldn't do just at the first follow up at 6 weeks because unnecessarily the patients will go on since the TSH is still so low. So what's happening? Maybe the drug is not working. So we tend to look at the T3, T4 and assure them, see, they are within the normal range. The TSH, of course, maybe by the time we feel that we may be able to gradually reduce or withdraw the drug. At that time, maybe TSH also needs to be shown to be within the normal range. That's been my approach. Professor Jackman, a quick
One comment. So only thing I fully agree with you. Only thing is, suppose you are treated. You are said that the patient is 6 weeks only. Suppose you are treated for 3 months and normalized, and you are maintaining a dose to small dose. There, I think T3 is more important because the first sign of rash may be increase in T3.
Right.
That is a person who has been treated to normal euthyroid state, and you are continuing the treatment for maintaining for 18 months, 16 to 18 months time. At that time, whether the dose is enough or not, the first thing is the T3 will be going up. T3 may be useful in that time, the first sign of relapse.
Right.
Otherwise,
So
I
we
fully
have-
agree with you.
Yeah, absolutely. So we have a number of very important questions in the chat box. So Dr. Jitendra Kumar, thank you for raising those important questions. One is, which hormonal tests require specific timing of day for blood collection to diagnose endocrine disease? So maybe Dr. Ashraf, we already talked about TSH diurnal variation, but that's possibly less important. But any others that you can think of and suggest?
Yes, that's a very valid question, and that is what is all about jinx of endocrinology. And the dynamic testing, the endocrinology actually means that when you have a thorough knowledge of interpreting an endocrine test in times of the duration of the time of the sample taken. Number one, what what age the sample was there, then at which stage of life, pregnant, non-pregnant, neonate. So it varies from time to time. So conventionally, we know, for example, if we take one by one, cortisol excess, and if you say ACTH, CRH, as well as cortisol, you usually take early morning, and that is the when you get the maximum of the sample. And if you take late night, that time you should have the what is called the lowest of that analyte. However, as an endocrinologist, we can interpret a sample in any time. That suppose somebody comes with me a random cortisol, I can make a judgment. But if we take a cortisol sample early in the morning or late night morning, we will have a reasonable understanding that what this test means. Similarly, if we are doing growth hormone, we know the pulses of growth hormone come early in the morning, so morning level should be high, and usually after sleep it comes higher. Then if we are doing serum testosterone level, you should take it in the morning. Again, if you are doing the gonadotropins we also may take according to the cycle of a woman. In man, you can take any time. However, a morning sample would be preferable. So the actually interpretation sample can be taken anytime. The interpretation is most important, that we should record the time, what time we have taken the sample.
And
One thing about prolactin you did mention, you
yes,
require multiple samples, prolactin.
Yes. So
morning
there are
sample.
other sample, like we take pooled sample, prolactin, even gonadotropins. We will need take pool sample. Here I should say for other information of others, that what happens is generally in these private labs, because there are so many labs which have actually proliferated, like with the unregulated, and our clinicians and our people think alike. They give samples anywhere. So some of the hormones like parathormone, like ACTH, like insulin, C-peptide, and growth hormone, these samples need cold chain. They need to be processed very properly. These samples get damaged. We have erroneously diagnosed a lot many growth hormone deficiencies when the sample has not been taken properly. So those things have to be understood.
Right. So Sandeep, yeah, you wanted to say something?
Yeah. So, just on a lighter note, today I had a patient who was absolutely distraught. She is a lecturer in a college in Ujjain. He came and she brought a report and she says, I have an abnormal HDL. So I've stopped eating everything fried. Her HDL was 64, it was highlighted in that report.
Okay.
And
Nice.
LDL was 88.
Okay.
So sometimes these labs will highlight and they've written high in front of it in
Okay.
bold letters. And she got so scared. So it's very big problem. You have to choose your labs well.
Sure. And
Yes, there is a problem. For example, you were talking about free T4 or free T3. We know you need equilibrium dialysis for these
Yes.
analytes. Now we don't have those things available. Every Tom, Dick, Harry does free testosterone, free T3, free T4, and they come erratic and people get scared, of course.
right. So only recently, once again, probably we are seeing a tick in the number of cases of COVID. Though of course, we are not seeing, fortunately, severe cases of COVID. So the question we have got is from Dr. Kotaku, and that's to do with COVID-19. And what lady or gentleman, I don't know, Dr. Kothari has, of course, pointed out that it's been reported that COVID-19 can cause autoimmune thyroiditis. Would you recommend thyroid screening in every COVID patient after recovery? If yes, at what time, how frequently? Professor Jayakumar, would you like to take that?
Yes, thank you. I think I have not managed so many COVID patients, but
It's
one thing
post-COVID, after recovery.
one thing is that it is well known that COVID virus can attack the thyroid hormone and produce subacute thyroiditis. And not only that, even vaccination, COVID vaccination is also as an autoimmune reaction can produce thyroiditis. But screening all COVID patients after recovery for thyroiditis is too much from my side. I think if the patient is having complaints, the patient says that I'm feeling tired, weak, losing weight. So symptomatic, if the patient is having symptomatic, and you always think about the possibility of a subacute thyroiditis, which may be accompanying following the COVID infection. So then you do it. Not
Right.
every Tom, Dick, and Harry who had a COVID, you do it after 6 weeks. You see, it can come after usually 6 to 12 weeks is the usual time. 6 weeks to 3 months, you get this reactions which are related to COVID, but that does not mean it can't come later on or it can't come early on. So when the patient is having symptoms, you do it, not as a prophylactic screening, as the other Dr. Sandeep said, you will create more patients without any symptoms. On small outpatient, they will be after it.
Right.
So
Dr.
can I just
Kothari,
add a little bit there? Our experience, that what Professor Jayakumar really said, that there has to be a temporal association of the COVID incident and then the thyroiditis symptoms and signs. So we had experience, we reported 2 cases, and one of my boys did a meta-analysis of the all 125 cases which have been in the literature. And this is currently under review under European Journal of Thyroid. I don't know whether they take it or not. So we have also done meta-analysis of all the cases which have happened because of the vaccination so far, which have been reported. So temporal association, as he rightly said, is very important, but we should not do it in every case.
Yeah, so as Professor Jayakumar suggested that based on symptoms, you do check in every patient. I don't think there is yet any indication that you should. As Dr. Ashraf Ghani has suggested, that you need not possibly go on checking. Maybe if you do maybe in 8 weeks or 10 weeks, possibly you can look at the effect. So we go on, sorry, we are going back to glucoses, HbA1cs. So because we have Dr. Bujwal, who has raised an issue. So he's got a pregnant lady whose HbA1c is normal. Fasting glucose is abnormal. Urine glucose is 2 plus positive. Do we label and treat it as GDM or wait for 1 month and repeat the reports? Who wishes to pick up? Sandeep, yes?
Thank you. So why I raised my hand is just recently I had a lady who came with 2 plus glycosuria, with normal blood sugars, with normal A1C. In fact, A1C was less than, in fact, it was 4.8. So in pregnancy, sometimes you can have normal glycosuria as well. So you don't need to treat it at all.
But
But
we also know
Sandeep,
that
he was, I think I heard that there was fasting was high.
Yes.
fasting is abnormal is what's stated. And we also know that in pregnancy, the A1C can be falsely slightly on the lower
Falsely.
side.
Yes.
Right. Yeah, Sandeep, please go ahead.
The fasting was normal, isn't it?
No, it was high.
It said fasting is abnormal.
It
It's
is some
abnormal. Oh, yes.
115
Yeah.
or something. Yes.
Oh, yes.
But
Oh,
in-
yes. Oh,
That
yes.
was the catch. Yeah.
Okay, okay. So fasting, if it is high, then definitely you have to be on your toes to then do the glucose challenge, whether you do the 75-gram non-fasting or you do the 100-gram 3 times. But you have to diagnose the lady well and immediately institute. And what was the week of pregnancy?
that wasn't specified.
Yeah.
That's
So
not there.
usually gestational diabetes is beyond 20 weeks, but not, we are getting lots of women who have been diagnosed diabetic in the first, high sugars in pregnancy with even high A1Cs earlier in the pregnancy. So you have to be careful. So if it is like 20 weeks when beyond, then of course you can say that it is the gestational diabetes, the pregnancy which has led to the rise in blood sugars. But now that we know that lots of girls are having polycystic ovary syndrome, and you have lots of girls presenting with pre-gestational diabetes in the first few weeks of pregnancy.
And very correct. I agree with you. And one more thing is that criteria is there that you do a 3-point test and 2 must be abnormal. If suppose one is abnormal, here from the history it appears that only the fasting is elevated, but the rest are normal with the glycosuria, which you will explain on the basis of their pregnancy-related glycosuria. So even one, then you don't say GDM, you can say glucose intolerance associated with pregnancy, and even on abnormal reading. And I personally feel if the fasting alone is elevated, that is more than 95, she must be given the benefit of a metformin therapy so that the fasting will be taken care of, and she must monitor it regularly.
Yeah, and unlike in non-pregnant state, we do not have a lot of time at our disposal. So waiting for 1 month is not enough. It's not good practice. Maybe waiting up, maybe repeating after or within a week should be the norm, I feel.
Right.
Absolutely,
So,
absolutely. And I will also suggest that in such situation, the key is repeating this, because many times you may get erratic lab values. Labs may deceive you, so we should repeat. That is the key.
right, right. So, yes, Sandeep, quick.
Quick
Yeah,
point. Sometimes you may actually have, even in a non-pregnant adult, you may have a fasting which is higher and a post meal which is lower due to hepatic glucogenesis. And there are so many patients, and sometimes they present with post reactive hypoglycemia, and
That
they
is
turn out
well.
to be,
That is okay. That is okay. That is the
yeah.
early onset of diabetes, and you have a reactive. That is a common phenomena. Yes,
right.
but
This is
pregnancy
for
is the key
the
here.
Yeah. So
this is
we are
for the benefit
still,
of physicians.
yeah,
Yeah.
yeah. We are still in the area of diabetes. We somehow cannot come out of it easily. So, uh, Dr. Ashraf,
Yes, sir.
you do a lot of studies, of course, I know, as spearheading that ICMR PCOS study and so on, doing field studies. But how do you look at point of care A1C test? Point of care.
Yes, I think if you remember, sir, by the NSGP guideline is that you should have a robust methodology, maybe HPLC, for doing an HbA1c test. Although there is an ease of convenience for point of care testing, and a country like ours, it may have a benefit, but the question is the variability which has been seen with these tests. They may be good for screening, however, their specificity is very low. So if some abnormal person is picked up and then you confirm it from your standard lab measurements, at that time you can disprove. But if you miss out, point of care may come very handy in our population.
Right. Thank you. And Dr. Jitendra Kumar Dayalal Shah uh, has found that Professor Jay Kumar is on the panel. So he has sent in this important issue for you to solve: how to differentiate subacute thyroiditis causing raised T3 and T4 from hypothyroidism. And then, of course, as a sub question is asked, what's the treatment of subacute thyroiditis? We may or may not go into that, but it is a first answer.
Okay, thank you very much. See, I think the only thing as a physician, practicing physician, when a case of hyperthyroidism comes, don't jump and start treating with the carbimazole or antithyroid drugs. Make sure that you are really dealing with the hyperthyroidism autoimmune disease like Graves, or is it only a manifestation of subacute thyroiditis? Because the treatment is entirely different. One is only supportive therapy for subacute thyroiditis with hyperthyroidism, which is a transient phenomena, whereas for Graves' disease, you have to decide about the medical, surgical, radioactive treatment, and decide about a long-term treatment pattern. So the first thing is history is the most important thing to start with. If the patient is having neck pain, fever, loss of appetite, aches and pain, and investigation, routine investigation for we are showing a leukocytosis, elevated ESR. This should sound to you that, okay, you are not dealing with a classical case. It looks like a subacute thyroiditis. So any condition, and suppose the patient is having a diffuse goiter, that means it has been there for some time and is having some eye signs and all those things. Then you may be, and without any fever or pain, you may be having landing with a Graves' disease. So this is the clinical differentiation, but the confirmation is by doing two things. One is both will show T3, T4 elevation and TSS decrease. But if you can have an assess availability of a radioisotope, that is technician thyroid scan, that is the best one. That will give you one has got a flat or zero uptake values, whereas other one have high one. Second thing is TRH receptor antibodies is other one. But the problem with the TRH receptor antibodies, there are two types, stimulating and inhibitory. Which one in India, you get only single test TRS receptor antibody, whether it is they are really how much is contributed by stimulation is no. But we use it in a condition like pregnancy, first times of pregnancy, whether you want to know whether you are dealing with a case disease, where you cannot submit a patient for a isotope scan. So this is the differentiation mainly. So leukocytosis, high ESR, and a technetium scan to confirm the result, or a TRS receptor antibodies which is negative.
Right. And of course, if you're looking at the duration of thyrotoxic symptoms, if they are there for several months, for 6 months, 1 year, then it's unlikely to be subacute thyroiditis,
Yes.
like the hypothyroidism. Right. So, Professor Ashraf Ghani, so this is for you from Dr. Jyoti. How to approach a
I'm in a
45-year-old
meeting.
lady with oligomenorrhea and headache? What lab tests are recommended and order of investigations?
Thank you very much, sir. Thanks for Dr. Jyoti for so she is saying 45-year lady. She has oligomenorrhea and
Headache,
and
headache, headache,
headache.
Shardar.
Headache. Okay. So, first of all, we have to see that if this lady has oligomenorrhea around 45 years of age, oligomenorrhea could be just a menopausal story. So, it could be that you can start menopause. Now, if the headache, heart flush, other things could also be part of the menopause. Now, we have to be very sure that if the headache is significant, if this woman has galactorrhea, we should check. If she has galactorrhea, then first thing is that this lady may have a pituitary lesion. Like, we should first do thyroid function. If thyroid function is normal, then we should do prolactin. If prolactin level is high, and if you have galactorrhea, then most likely we may be dealing with what is called prolactinoma that can explain headache as well as the oligomenorrhea. If suppose we don't have high prolactin and galactorrhea, then headache could be evaluated as on its own merits. Like headache, you can have vascular headache, you can have any other reason for headache. So it could be just a menopause. Then we may have to do FSH. If FSH is elevated, it is showing upward trend. That means patient is going to menopause.
Right. Good. Let's scroll through the questions. So Dr. Jyoti has also asked on investigations and approach to precocious puberty. Now that's a vast area, but Dr. Sandeep Julka, would you like to quickly highlight how to approach precocious puberty, let's say in a boy? Yeah, please unmute yourself.
Thank you, sir. So precocious puberty in a boy. So precocity in boys is a little rare, but then yes, it can sometimes have serious consequences. And when you compare the boys with girls, it is more often than not idiopathic in girls, but in boys, you usually have some underlying serious endocrinopathy leading to precocity. And it also depends on the tempo of precocity, the age of onset. So for example, when small kids, boys with precocity, then sometimes you have what are hypothalamic hematomas. I've seen few cases of hypothalamic hematomas with gelastic seizures and precocity. I've seen cases with testotoxicosis, which is peripheral precocity.
Rare. Very, very rare.
Yeah. So they are peripheral precocity. Then you have McCune-Albright syndromes. So you can have children with recurrent fractures, with polyostotic fibrous dysplasia and other endocrinopathies like thyroid and precocity. So it is at the age of onset
Sir, you are not mentioned the commonest one, CAH.
Oh, yes. CAH. Yes. Now, CAH is when either at birth, if it is a salt wasting, that the child will present with adrenal insufficiency, darkening of skin, and hyponatremia, and the child at times will have a history of a sibling death with diarrhea. So if the pediatrician is alert, the pediatrician may do a 17 OHP. Nowadays, you actually have a battery of tests which is done at birth, and lots of pediatricians are doing screening for thyroid and CH at birth as well. So all these.
So what are the tests that you would be advising in a case of a suspected precocious, in a case of precocious puberty, especially when you talked about the central cause and peripheral cause? So how do you distinguish?
So I think the most important tests would be to do a LH-FSH, testosterone, and a thyroid function as well. Thyrotoxicosis may itself present with early, and sometimes hypothyroidism can have macroorchidism, and you may misdiagnose. So precocious kids are tall. If you have a short child with large testes, think of thyroid. So these are the tests, and then of course, then you will gradually keep increasing tests as well.
Yeah, so CNS imaging will come if you find that it's a GnRH dependent precocious puberty, then CNS imaging would be indicated. So we come back to Dr. Ashraf Ghani. So your hospital nurse, young lady, 25-year-old lady, seeks your advice for hirsutism and irregular periods. So how do we evaluate her?
Okay. So what is her age?
25, 26?
Okay, 25. Yes. So that is a usual common story. In my clinic, you will have 10, 15 nurses with hirsutism and oligomenorrhea. Somehow, for a surprising situation, PCOS is very, very common in our population. When I was telling this to other people that PCOS, they were saying, oh, Kashmir is a rural area, you should not have common disease. Somehow it is very common here. We do have many patients coming back. When a woman of 25 years age comes with hair growth and oligomenorrhea, that means she is qualifying NIH criteria only on the symptoms. So because you have oligomenorrhea means you are not ovulating. That is one. Second, when she has hair growth means she has high androgen levels, so she qualifies NIH criteria. This disease means she has a very serious PCOS because NIH criteria is a stringent criteria. Now, third is Rotterdam criteria. Sometimes you may have ultrasound also along with, and that shows a polycystic ovarian morphology. What you have to do is that although for common clinical practice, if you are doing thyroid function, if it is normal, woman is euthyroid and she has testosterone elevated but not very high, more than 200 in the tumorous range, and that you can make a reasonably, you can make a diagnosis of PCOS. In our population in Kashmir region where we have more of consanguinity, non-classical CAH is also common, so we do 17-hydroxyprogesterone also. But I think if you do not have a family history in other parts of the country, 17-hydroxyprogesterone may not pay much results, because in our cohort of 10,000 women, we have found non-classical CAH in only 2 ladies. So that is a very rare disease. So whether you do 17-hydroxyprogesterone or not, if clinical setting is there, then do. Otherwise, you may not waste money on those. So if your patient has galactoria, then you may do prolactin. Otherwise, you can do away with that also. So, but testosterone is to be done because that will gauge us. On one hand, it will support the PCOS diagnosis. On the other hand, it will rule out any adrenal ovarian lesion, that tumor. We have to understand that testosterone assays have same fallacies which happen in other issues in women. So testosterone assay should be done from a reasonably robust assay method. So if gonadotropins are within the normal range with LH higher, LH ratio, LH-FSH ratio higher, may or may not be. In that situation, we make a diagnosis of PCOS. So although diagnosis of PCOS is the diagnosis of exclusion, but it takes almost 5,000 rupees to confirm a woman of PCOS. But PCOS being such a big burden in the country, I would suggest that we should not tell clinicians to do all the tests, battery of investigation, because it will worsen the economy of our country, because there is almost every third, fourth woman is affected with PCOS, and these repeated ultrasounds and hormone testing may put a burden. So we should minimize the tests. I think thyroid, if TSH is normal, then we should do one testosterone LHFSH with these clinical symptoms, and you can reasonably say that I am dealing with a patient of PCOS.
My question is, Doctor, sir, if we have got already clinical evidence of hyperandrogenism, like hirsutism, acne, and all, do you require a biochemical confirmation? Because the criteria says Rotterdam criteria clinical or biochemical hyperandrogenism. So if somebody is having a classical hirsutism, do you want to confirm it with the testosterone value?
So actually for PCOS we don't need, but what I was telling that basically this hair growth and oligomenorrhea should not be because of any androgen secreting lesion from ovary or adrenal. Then at that time the higher end of testosterone has to be seen, and also non-classical CH should not be missed. So these two things are there. Otherwise, we have reasonable understanding this is PCOS.
Right. So we are ending the end of our hour allotted to this discussion, and I have been informed a short while back that more than almost 850 doctors have joined from across the country to learn from all of you, and hopefully that helps them to also improve their own clinical practice. Can I ask maybe a final one, maybe to Professor Jayakumar? So, patient with recurrent kidney stones obviously will be going to the urologist. Is there any role for the endocrinologist to step in and help, Professor Jayakumar?
Yes, you put a very difficult practical point, because the recurrent renal calculi is a condition where majority of times you are not able to pinpoint a pathological lesion. And the poor patient, even my wife had it 3 times, so, breaking and all those things, unable to find out the cause. So the question is, but it goes to the urologist, but it is our duty. There is a small percentage of renal calculi which is due to an endocrine disorder, and the commonest one is hyperparathyroidism, because the good old days we have learned hyperparathyroidism, the disease of bone stones and groans and all those things. So it is there. So a serum calcium and phosphorus and a PTH is a must for a person who is getting recurrent stones where you are not able to get on. Second thing is uric acid. Uric acid, high uric hyperuricemia can produce stones. Then urine microscopic examination of so much of oxaluria, all these things may give a clue that you are maybe dealing with a metabolic disease which may be contributing. But I personally feel that it's only about 20 or 25% of this patient will less than that only you will come across the endocrine cause. Majority you will not be able to find out a cause. This
absolutely right. So, but
can I just add one point for this?
Yes.
What Professor Jayakumar rightly said, that most of these stone diseases do not have a cause; they are idiopathic stone disease, and we have 1 or 2, 3 conditions in endocrinology which we have to deal. I have one important point to share about the practitioners here, that whenever any stone disease patient is seen by a urologist or any clinician, they first do PTH, and PTH invariably comes elevated, and they make us do so many runs of serum, urine, calcium, and nothing comes out. This is because vitamin D deficiency in this country is so common. 70 to 100% is common, PTH is likely to be high
Yes.
and it wastes a lot of resources. So we should generally see that we can give without testing vitamin D a dose of vitamin D treatment and redo PTH if it is high, and that can save us from a lot of exercise.
Once
Thank
again,
you.
yeah, very, I mean, wise words from Dr. Ashok Ganesh. Sanjeev, yes,
So, 2008, we published our series of cases in Indian Journal of Endocrinology, Metabolism of Recurrent Renal Stones. And for all the physicians, they can look up, it is freely available on the net, about causes of recurrent renal stones and the endocrine and the non-endocrine aspects of it, distal RTA and hyperoxaluria and all.
yeah, right. So we wind up because we still have one question in the chat box Dr. Yadav was put in, which is evaluation of infertility in a 37-year-old man. It's secondary infertility because he already has a girl child of 7 years, but now he's complaining of infertility. He has got diabetes on metformin, but which is well controlled, A1C 6.1. Wife has absolutely normal reports. So it's likely male cause for infertility, which is acquired, I mean, despite having a girl child of 7 years. So Sandeep, quick, what should we investigate for?
So let me get it correctly, sir. Male, we are talking about male infertility, already has a girl child.
Yes.
Yes.
And diabetes.
Diabetes,
And
well
he's
controlled diabetes on metformin only.
controlled on metformin. Okay.
Yeah.
So fertility is again very important to do the proper examination, the testicular volume, the testicular size, the consistency. That will give you significant amount of information. Do a urine examination for retrograde ejaculation. Sometimes with autonomic neuropathy, you have retrograde ejaculation and the patient may not be able to conceive. Then do a semen analysis to see for fructose. If there is some block anywhere, that one can be diagnosed. That is one. Other conditions of hydrocele and all can be found out. Then of course, sometimes you can, if you have small testis soft that shows post-pubertal testicular atrophy, then you can do a testosterone FSH. You may find a high FSH beyond 18. Think of primary testicular failure. Post maybe has had orchitis sometime. He's got hydrocele. A low testosterone can be associated with other endocrinopathies as well. So, and
And
rarely,
so in this
yeah.
context, maybe prolactin also. If
Okay, but one mentioned
It's low.
hypogonadotropic hypogonadism is a one associated with metabolic syndrome. Hypogonadotropic.
Okay. Right, yeah.
And also never forget to do a pooled prolactin in such a case. I've had a case where we actually found a large pituitary adenoma in a male with infertility. And of course, severe hypothyroidism with sometimes you can have co-secretion and then somebody with a prolactinoma treating with cabergoline, the tumor melts away and the patient can become fertile again.
Right. So thank you very much. So I think we could go on and on because endocrinology deals with so many investigations, but we have to respect the time. And I'm happy to share with you that at the current moment we have 1150 doctors following you all to learn from you. So I think it's difficult to summarize all that we have learned, but it's very important to go back to the basics, which all our learned endocrinologists have pointed out, that clinical examination, history taking are all extremely important despite the availability of so many investigations. And we have also got to advise the investigations carefully. Cannot do so indiscriminately because they cost so much of money, because of lack of good number of standardized laboratories, because sometimes if you advise for too many tests, you'll come up with abnormal results, which may just be labomas, lab errors, or lab-related issues, rather than patient being abnormal. So we need to be aware of all of these, and there are different dynamic tests that we need to do that Dr. Ashraf Ghani has referred to, but we will go into the details of, which make endocrinology such an exciting but also satisfying discipline to pursue. So thank you, all of you, for especially our panelists this evening, Dr. Jay Kumar, Dr. Sandeep Julka, Dr. Ashraf Ghani, all very good friends. Thank you for joining in, and all of you physicians from across the country for showing your interest. And I'll also thank Intus for following up very meticulously this event month after month, and spreading the wisdom and the knowledge of all these senior people that we get across the country. So over to you, Mr. Anand from Intus, for the final words.
Thank you very much, sir.
Thank you.
My name is Praveen. It is my privilege to be proposing vote of thanks to everybody. Firstly, sir, I would like to thank Shubhankar Chaudhary, sir, for being a patron for this program, being the anchor of this program. Sir very correctly said in the beginning that we started with the practice pearls in endocrinology, then it evolved into this endocrine talk show. And we have seen such a wonderful transformation of the program. And this program has become even more liked by the physicians, and it has become more interactive. No doubt today's series was no exception. It was very well liked. I think endocrine investigations are of great importance. So thank you very much, sir. I would individually like to thank all the panelists, Dr. R.B. Jakumar, sir, Dr. Sandeep Zulka, sir, Dr. Shubhankar Chaudhary, sir, and Dr. Ashraf Ghani, sir, for being here. And the way you discussed the various endocrine disorders and the tests associated with us would go a long way in serving the clinician's need. I would also like to thank, as sir said, today it was attended by close to 1,200 physicians from all across the country, 1,199 to be precise. So I think they also must have found this program very useful, because the design of the program is like that they get the basic to get to know. That would go a lot of, that would go a lot in serving their clinical needs. So I would also like to thank my technical support team here, which is present here, and the field people who have, as sir said, very diligently followed it with the clinicians and have made them to attend. So that's all what I had to say. Thank you all again. Thanks for coming, being online.
Thank you.
Thank you for making this wonderful program. Thanks. Have a nice evening and a great weekend ahead. Thank you, sir.
Thank you, sir.
Thank you. Thank you,
Thank you, everybody. Thank you.
Thank you. Good
Thank
night,
you,
sir.
Sandeep.
Good night, everybody.
Thank you, sir. Thank you very much.
Thank you, sir.